Welcome to part 3 of the immune system. In this we're going to talk briefly over antibodies, antigens, which I know we've already talked about, but it's just going to be kind of like a real fast review of it. We won't spend a lot of time on it because I want you to kind of just to bring it, because then we're going to be talking about altered immune responses. So we're starting to get into really kind of some of the fun stuff now. And thank you once again for being so patient. So, a reintroduction to antigens and antibodies. Antigens are molecules capable of stimulating an immune response. Remember, antigens do not belong. They're the black ninjas in the world of evil. Just kind of think of them as that. And the antibodies, we also call them immunoglobulins, and we've already talked a little bit about immunoglobulins. And they are the Y-shaped proteins produced by B cells of the immune system in response to the antigen. So these are the ones that as soon as the antigen enters the body, the little black ninja antigens enters the body, the white ninjas, the antibodies, start going towards them, tag themselves, and get the immune system going. Antibodies as receptors. Antibodies can attach to B cells and serve to recognize foreign antigens. So remember when we talked about what antibodies do, how they get the immune system going and stuff. So this is a picture that will show you kind of, there's a B cell and then you see an antibody, those little arms or little legs that attach to it, and then it's got an antibody receptor function. So you see these little microbes going by. Is this really need to be here? Does it not? If it feels that it does not need to be there, then it's going to send off a response, and the immune system is then going to be activated. Antigens as effectors. Free antibodies can bind to antigens, which tags the antigen for the immune system to attack and destroy. So basically, just remember, this is just a review. Once again, antibodies are essential simply because the immunoglobulins attach to an antigen. It's like, this is normal, this is not normal, which sends off, okay, comes, help save us, let's destroy it, or this is fine, this is just a different type of a cell we already know, it's fine, we're okay with it, just let it go. So it's either going to get the system to attack and destroy it, or it's going to allow the antigen just kind of just float around in there and just kind of be okay until maybe the body decides, oh, I don't like this cell, let's attack it. Another picture to help you kind of kind of put it in your mind is antigen as effectors. Antibodies are immunoglobulins. They belong to the gamma globulin fraction of serum proteins. They are either going to be Y-shaped or T-shaped polypeptides. There are 2 identical heavy chains, 2 identical light chains. All immunoglobulins are not antibodies, and we'll not really, that's starting to really get into some depth, and so we really won't delve into a lot of this, but we will look at what it does to our body, especially with the 5 kinds of antibodies that we see that we deal a lot with. If you're really interested in a lot of it, maybe going into like research for healthcare, to where not looking at necessarily how things work in the hospital system, but maybe working for like the CDC, where you can get a chance to see how diseases and stuff like that affect the body and which antibodies and all this stuff. I mean, that's really getting into a really in-depth arena. Hypersensitive reactions. Sometimes the immune system's response is overreacting against the foreign antigens, or reacts against its own tissue, reacts against self, resulting in tissue damage. The responses are termed hypersensitive reaction. Autoimmune disorders, a type of hypersensitive responses, occur when the body fails to recognize self-proteins and react against self-antigens. And this is found starting on page 197 of your textbook. Hypersensitive reactions are going to be classified according to the source of the antigen, a time sequence, whether it's been an immediate or delayed response, or immunological mechanism causing the injury. Now there are 4 types of them they're gonna be classified as type 1, type 2, type 3, and these are considered immediate and are examples of humoral immunity. Your type 4 is a delayed hypersensitivity, and that is classified under cell mediated immunity. Starting with type 1, this begins on page 197 of your textbook. Type 1, which is your immunoglobulin E, which is, if you remember, is 0.002%. It's found in the plasma and intestinal fluid. It causes symptoms of allergic reactions. This is a mediated reaction, anaphylactic reactions that occur in susceptible people who are highly sensitized to specific antigens. Immunoglobulin E antibodies are produced in response to the allergen and have a characteristic property of attaching to mast cells. So they are produced. Immunoglobulin E's antibodies are produced in response to an allergen, and they have a characteristic property of attaching to mast cells. Antibodies are produced in the first exposure to the allergen. So the very first time you're introduced to the allergen, antibodies are starting to be produced. A clinical manifestation of an anaphylactic reaction depends on whether the mediators remain local or become systemic, or whether they affect particular organs. If you look on table 13-9 on page 198 for allergens that cause anaphylactic shock. So this one on 198, it breaks it down. It's kind of over in the middle of the page, and it'll say allergens causing anaphylactic shock. There are different things. Remember, it's not necessarily about eating peanuts, but it could be medications. When we talked about that, stop and think about in the drug allergies, in the side effects. You know, if it's in bold red letters, this is a serious life event. So there are some of them, such as aspirin or sulfas, that can cause an anaphylactic shock. Foods: eggs, milk, nuts, peanuts, shellfish. Remember, we've talked about shellfish a lot, especially when we're dealing with stuff with like iodine. Then also treatment measures. Allergenic extracts used in immunotherapy. So if you're going through, and if you remember during the guest lecture and stuff when Christy was talking about doing the skin testing, they keep EpiPens by because the person might have an anaphylactic reaction. It can happen. You're testing and you're introducing the allergen, and it may not even take just inserting the needle into the skin, and they can have that severe of a reaction. Remember when she used the story of the lady that was really allergic to peanuts, and 150 feet away, somebody, or even 50 feet away, I believe, was eating one of those Ritz crackers with peanut butter in it, and she caught the whiff of it, and she started having problems. There are some people that are highly sensitive and highly susceptible to their allergens. Insects and worms. People are allergic to bees, yellow jackets, wasps. Animal sera, like diphtheria serum, when we're talking about rabies antitoxins, snake venom antitoxins, tetanus antitoxins. So maybe these are things that are, stop and think what rabies is taken from. It's taken from an infected person, an infected animal, and it's made into a serum, just like snake venom. So the person could have an allergic reaction to that. That really poses a problem with it. So being careful, with them is very important. So if you look on table 13-8 on page 197, and table 13-7 on the same page, it talks about table 13-7 talks about types of hypersensitivity reactions. Type 1, you've got your mediated. It breaks it down. It talks about type 2, type 3, type 4. Remember, those are going to be the ones that fall under the humoral immunity. Table 13-8 talks about mediators to allergic responses. Mediators of inflammation and their mechanism of action are present. So we're talking about anaphylaxis, histamine, kinines, leukotrienes, platelets. These are the things that you're going to see during an anaphylactic reaction. If you draw labs and stuff, you're going to see all this stuff elevated with that. It is very important that you recognize signs and symptoms of anaphylaxis. I know we have talked about this in some, but we're going to talk about it a little bit more, and it's very important that you're able to recognize it so that as soon as you start seeing it, you can start treating it right away, because anaphylaxis can lead to death if we don't treat it right away. So this is a picture of the systems that are affected by anaphylaxis and what you're going to see. You're going to see swelling of the conjunctiva, you're going to see swelling of the eyes, you're going to have a runny nose, swelling of lips, tongue, and or throat. Central nervous system, they're going to feel lightheaded, they might have loss of consciousness, they might be confused, they might have a headache, they might become extremely anxious. My daughter, when the one that was here lecturing, she may have, when she is exposed to an allergen such as a nut, she wouldn't really start having any swelling or anything. She would just start feeling anxious, and then she would start having some swelling of her lips and her tongue. Her lips would start turning blue because of the lack of oxygen, and then she really would become really anxious. She didn't have swelling of the conjunctiva, but she would start having respiratory issues, shortness of breath, wheezes, and she has asthma, so it was really exacerbated. Her skin, she would get really itchy, and she would break out in hives. Some people will have pelvic pain, some people will have gastrointestinal problems, they'll have crampy abdominal pain, diarrhea, vomiting, and some people in the severe anaphylactic reaction will have loss of bladder control. So this is not necessarily all-encompassing list, but these are the main symptoms that you're going to see with anaphylaxis. So please become familiar with it, so you know if you see somebody having this, you need to be communicating with them. Do you have an allergy? What are you allergic to? Do you typically use an EpiPen? Especially if they say they're allergic to like peanuts, bees, you know, walnuts, things like that. Sometimes, you know, they're going to be able to say, you know, they're going to be wearing a medic alert. They're not going to be able to say, they're going to have a medic alert bracelet on that says, hey, I have an allergy to this, or they're going to wear a necklace with it. My daughter has an app on her phone. Allergies. They are considered a type 1 hypersensitivity because the body is responding to it. Remember, a type 1 sensitivity is to an antigen, such as, you know, pollen, food, drugs, dust. The antibody is going to be the antibody involved is going to be immunoglobulin E. The mediators are going to be the injury. Remember, it's going to be a release of. So typically, if you're exposed to an airborne substance, which is the most common form of it, such as dust, pollen, molds, this is where you get hay fever. This is where people have allergies to dog dander. This is where you have, you know, people can't be outside because the ragweed is really high. This is what we're talking about. This is where the body sees, typically for ragweed, the pollen and stuff is typically is seen as harmless, but for whatever reason the body sees it as, oh hey, well this is a threat, and the immune system kicks in. Then you're going to start, this is where you start seeing you have sneezing, runny nose, watery eyes, and you're going to treat it with the antihistamine. You're going to treat it with something like maybe Benadryl. You're going to treat them with something like Claritin, something like that, to help kind of stop the symptoms with it. Type 2 hypersensitive reaction. This is also known as a cytotoxic or cytolytic reaction, found on page 192 of your textbook. This is where reactions involving the direct binding of the immunoglobulin G and immunoglobulin M to an antigen on the cell surface. Antigen-antibody complexes activate the complement system, which mediates the reaction. Target cells frequently destroyed in the type 2 reactions are erythrocytes, platelets, and leukocytes. The most commonly known autoimmune disorders that occur because of this are your ABO incompatibility transfusion reaction. It means when you're transfusing blood, you give somebody that's A negative, A positive blood, you're going to have a problem with that. So this is why it's very important that, that you check what their that there are ABO compatibility. RH incompatibility transfusion reaction, similar to that of the ABO. It can be life-threatening. autoimmune and drug-related hemolytic anemias, and that could be because of a drug causing, a drug or medication causing hemolytic anemia. And leukopenias and thrombocytopenias, that could be some of your more caustic. You might see that more like along with your chemotherapeutic agents. Leukopenias, which is found on 251 to 252 of the textbook. Thrombocytopenias, 251 to 252 and on 253. Erythroblast fetalis, which is found on page 199, which is a hemolytic disease of the newborns. And then Goodpasture syndrome. That is found on 199. Goodpasture syndrome is also known as anti-glomerular basement membrane disease. It is a rare autoimmune disease in which antibodies attack the basement membrane in the lungs and kidneys, leading to bleeding from the lungs and the kidney, and also kidney failure with it. Type 3 immune complex reactions, found on page 199 in your textbook. If you also go back and refer to page 197, table 13-7, it also talks about it. It puts it in kind of a table that's easier to read. The antigen is going to be extracellular, fungal, or viral or bacterial. The antibody that's involved is going to be the immunoglobulin G and the immunoglobulin M. There's going to be complement involvement with that. So when we're talking about this, we're talking about tissue damage in the immunocomplex reactions, which are type 3 reactions, occur secondary to antigen-antibody complexes. Soluble antigens combine with immunoglobulins of the immunoglobulin G and immunoglobulin M classes to form complexes that are too small to be effectively removed by the mononuclear phagocyte system. Basically, the type 3 reactions may be local or systemic and immediate or delayed. The clinical manifestation depends on the number of complexes and the location in the body. Common sites for deposits are the kidneys, skin, joint, blood vessels, and lungs. Severe type 3 reactions are associated with autoimmune disorders such as systemic lupus, erythematosus, acute glomerular nephritis, and rheumatoid arthritis. Systemic lupus, or SLE, and rheumatoid arthritis we're going to discuss in our face-to-face lecture. And acute glomerular nephritis was discussed with your renal disorders. Now, type 4 is your delayed hypersensitive. Now, this falls under your cell-mediated immune response. The most common one of this disease is going to be, reaction, is going to be contact dermatitis, or a hypersensitive reaction to bacterial, fungal, or viral infections, and also your transplant. It means it's delayed. It's not happening right away. It's going to take up to 24 to 48 hours for you to have an occurrence of it. With contact dermatitis, this is going to be an allergic reaction. It is also a delayed hypersensitive reaction involving the skin. The reaction is going to occur when the skin is exposed to a substance that easily penetrates the skin to combine with the epidermal proteins. The substance then becomes antigenic, and over a period of 7 to 14 days, memory cells form the antigen. On subsequent exposure to the substance, a sensitized person develops eczematous skin lesions within 48 hours. So remember, first exposure is going to take a little bit longer. Second exposure is going to happen a lot quicker. And in some cases, it can take up to 24 to 48 hours for you to have a reaction to it. So, what are you going to assess for? What are you going to look for? On page 200, it shows you allergic disorders. You're going to do an assessment, diagnostic workup, a family history. It just kind of walks you through with it. It talks a little bit about the skin testing, the results of it. It just kind of talks to you a little bit about it. Social and environmental factors with it. You need to be familiar with it. Like we've talked about, if somebody says they have an allergy to a medication, well, what type of allergy, how severe, because this is part of your hypersensitivity with this. Also, you might want to ask them, do you have any allergies to latex, any sensitivities to latex? Do you have any allergies of any kind to whether it's laundry soap, try to find out what type of allergies that they might have, because there might be something that we use maybe back in OR that they have an allergic reaction to that we didn't realize. It might be they have an allergic reaction to the scrub we use, and there are different types of scrubs we can use and that we do have in place. We really need to know about latex allergies back in the OR, simply because there are some drains that we use that come in latex or non-latex. So we typically just go to latex. Not everything is latex free back there, so we just need to be sure that we're using latex free items if we possibly can with that person. So it's very important that when you're doing your physical assessment and you're doing your family history and stuff, you do ask them these questions. Do you have any allergies to anything? Do you ever break out with a skin rash, when you change soaps or whatever? A lot of times you won't see it necessarily in the hospital, but when you're in the clinical setting, be sure, I have this rash on my body. Well, have you changed soaps? Do you wear perfumes? Have you been exposed to anything? Questions you should be also asking is, have you changed anything in your diet? Have you started wearing new jewelry? Because a lot of allergies are to metals also. So just finding out, if they've been exposed to something new, and also is there family history, because a lot of these you will see sensitivities in families with that, like penicillins with it, and like with my family, we have with my severe allergy to morphine, the doctors have said we're going to put it down. We need to put it down with your children, especially after I had 2 of them react to the morphine with it. So finding out family history is also very important. Nut allergies also seem to follow in family history also. And this is just a continuation of the diagnostic studies and stuff that you're going to see in the textbook, kind of what they've gone over, different things that they're going to do, what they're looking for. You see on here, you're going to see a WBC, a white blood count differential with absolute lymphocyte count and eosinophil count to see if they're elevated. Because you could be having a reaction of some sort. You could be having a delayed hypersensitive reaction to something going on, to a medication, or they'll do these a lot with somebody that has a transplant to make sure that they don't have a rejection going on in their system. Now we're going to be talking about autoimmune disorders, which is why we have had the lengthy part of reviewing what the immune system is and stuff like that. So now we're getting into a little bit more of a few interesting details and stuff along that line. Now we're going to start discussing autoimmunity, what it is, the diseases, and kind of how the outlook is for them, and what is up, what causes them. And many of the autoimmune diseases, we don't know why. Basically, plain and simple, autoimmunity is a misdirected immune response that occurs when the immune system goes awry and attacks the body itself. Multiple sclerosis, lupus, and rheumatoid arthritis are examples. None of these can be cured, but drugs can help slow the progress of the disease. They're also going to help the patient that has been diagnosed with them to try to live a productive life for as long as they possibly can. The cause of autoimmune diseases are unknown. However, the principal factor in the development of autoimmunity are inheritance, which is the inheritance of susceptibility genes, which may contribute to the failure of self-tolerance, initiation of autoreactivity by triggers such as infections, which may activate self-reactive lymphocytes. Drugs can also be precipitating factors in autoimmune diseases, such as hemolytic anemia can result from Aldomet administration. Hormones are seen more in women than men have autoimmune disease. So they're saying that because of our hormones in our system, the way they fluctuate with the estrogen, progesterone, and all that stuff, that women are more prone to them than men. And autoimmune disorders are grouped into organic specific and systemic specific. On the next 2 slides, you're going to see a list of autoimmune diseases, and you can also find it in your textbook on page 205, table 13-13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13. 13 Some of them we've already seen, like in the endocrine system, you've got your thyroid gland, your Graves' disease, your Hashimoto thyroiditis, your pancreas, which means your insulins, your diabetics, the adrenal glands, your autoimmune, Addison's disease, skin, vitiligo, your muscles, your myasthenia gravis, Guillain-Barré, multiple sclerosis with your central nervous system. So as you look at the slide, you're going to see some of them like, oh hey, yeah. And think back to when we talked about some of the autoimmune disorders, and when we discussed endocrine system, or when you guys discussed with Lori Lynn renal disease. So just kind of think about some of these as you kind of look at them. We're not going to go into every one of them. We're just going to talk over a few of them, but just kind of look at them and think, oh yeah, it's because there's something wrong with the immune system, that it has gone into overdrive and it has decided to overreact in a lot of cases with these. Now don't forget though, some of these might be caused because of a medication, like some of your hemolytic anemias may have been caused due to a medication with it. So just kind of stop and think about what some of these were. The gastrointestinal, think about when Lonnie lectured you about pernicious anemia, Crohn's disease, celiac disease, IBS disease. Think about it has to do with the immune system. Something has happened with the immune system to where it has gone into overdrive to cause these disorders. Now most of these, there are no, if you look at ulcerative colitis, there is no cure for it. Autoimmune hemolytic anemia, there usually is not one with it. So a lot of these we're looking at, as we look at them, the cause sometimes is known. It could be due to drugs. It could be due to another condition. So that's why sometimes these conditions are connected together. Autoimmune with maybe an endocrine disease. It depends on what is going on, where the disease is, what is, all the factors playing into it that give them this disease. Now these three diseases are considered more systemic diseases. Remember, systemic is kind of system-wide. There's usually something that's going on system-wide. It's not going to affect just the joint, it's going to affect other areas with it. And you'll see that more as we discuss, especially rheumatoid arthritis and systemic lupus. You can find these, and I also included the page numbers that we can go to with these. So especially with your rheumatoid arthritis and your lupus or your SLE, those will be ones that we'll be discussing on PowerPoints and in class. Multisystemic autoimmune diseases. These are considered a spectrum of autoimmune diseases. They affect more than one system. Graves' disease, it affects it affects the eye, the ocular system. It affects the thyroid system. It affects cardiovascular. So a lot of these, if you look at it, it affects a lot of systems. I'll upload this to, like I said, a Word document so you can see it. So it says here, like Graves' disease, it affects the thyroid, the TSHR, abdominal, it affects different areas with it. So this kind of gives you an area, kind of a look at what's going on, what is happening, and you can see. So like I said, a lot of these are not going to affect just your thyroid. They're going to affect other areas. It's not going to just affect your joint. It's going to, or your muscles. It is affecting other areas of your body. This slide shows etiology of the autoimmune disease. You've got where it can start with, you've got in the center, you've got the autoimmune disease. So depending on what it is, it can be either genetic susceptibility, which means predisposing genes, you have them. Maybe it's a recessive trait and it skips a few generations and it comes prevalent in you. Severity of modifying genes and the disease suppressing genes. So it depends on what is going on genetic wise, whether or not this person may be predisposed with it. Gender, sex hormones, sex chromosomes, male versus female. Now remember what I said, in today's world with all the your transgenders and your people that have gone in for sexual reassignments, if you're born a male, your chromosomes are always going to stay a male. If you're born a female, your chromosomes and genes are always going to stay that. So typically a male who has had a sex reassignment surgery to make them become female, they are not going to end up with a disease that is typically only seen in females, if that makes sense. Factors yet unknown. This is somebody just, there's no family history, there's no genetic predisposition, they are not living anywhere where this is prevalent, and all of a sudden they end up with maybe like myasthenia gravis, or there's no family history of multiple sclerosis of MS, and they end up with MS. So factors yet unknown. They don't know why sometimes they cause them. Sometimes it's just a very random thing. Random variables that goes along with that. And then external triggers. Is it a virus, bacteria? Was it drugs? Was it chemicals? Was it pollution? Was it sunlight? Was it diet? Was it stress? So there's a lot of things that play into that they look at when we're looking at the etiology of the autoimmune disease. Apheresis, found on page 205. This is used to treat autoimmune diseases and other disorders, and what it is a procedure that is used to separate components of the blood, followed by the removal of one or more of the following components. Now when they do this, they're going to use compound words to describe any particular apheresis procedure, such as with platelet apheresis, which is the removal of platelets from a healthy individual to infuse into an unhealthy individual. Also used in hematopoietic stem cell transplantation to collect stem cells from peripheral blood. They can be used. Then they can be reused to repopulate the person's bone marrow after the chemotherapy. And leukocytopheresis is the removal of white blood cells and is used in chronic myelogenous leukemia to remove high numbers of the leukemic cells. So this is basically just a procedure that they've used and they've had good luck in to help treat some of the autoimmune disorders that we see. They will plasmapheresis is the removal of plasma containing components causing or thought to cause the disease. They use this to treat autoimmune diseases such as SLE, which is systemic lupus erythematosus. On that, and you can find this on page 205. It is also so what they're going to do is they're going to remove the plasma, and then once it's done, it is replaced by a substitute fluid such as saline or fresh frozen plasma or albumin. Thus, the term plasma exchange more accurately describes the procedure. It's been used, even though I've got SLE, systemic lupus up there, they also use it for Goodpasture syndrome and myasthenia gravis. And I've also seen them use it for thrombocytopenia purpura. Many disorders for which plasmapheresis is used are characterized by circulating autoantibodies, usually the immunoglobulin G class, and antigen-antibody complexes. The rationale for performing this therapeutic plasmapheresis in autoimmune disorders is to remove pathologic substances present in the plasma. The immunosuppressive therapy has been used to prevent the recovery of the immunoglobulin G production, and plasmapheresis has been used to prevent antibody rebound. So ends the part 3 of the voiceover of the immune system. This was the introduction into the autoimmune disorders and stuff. I wanted to do that and bring this over here on this PowerPoint so that when we start talking about the diseases, you already have a background into the diseases of what happens with the autoimmune disease. So it kind of gives you a leg up on what is going to go on with the lecture when we start talking about the autoimmune diseases such as lupus, chronic fatigue syndrome, rheumatoid arthritis, and then when we start looking at the immune diseases such as HIV, and when we talk about cancer also. So it kind of gives you a little bit of background, and we just kind of get this out of the way.